Hello, everyone. Welcome to the FST webinar with Dr. Danielle Marchildon. So hopefully more people get a chance to log in and you can start hearing us. Just wanted to introduce our speaker today. So this is Dr. Danielle Marchildon. She's an ND practicing in Orangeville, Ontario, which is a town that's northwest of Toronto. She earned her Bachelor of Science in Biology from the University of Waterloo, and she graduated from CCNM in Toronto with her naturopathic degree. She decided to move back to Orangeville to raise her 5 kids and start her practice. She sees a wide variety of patients, so she treats mainly families, mental health, fertility, digestive, skin conditions, chronic pain, weight management, and more. Dr. Danielle has been a longtime supporter of Rocky Mountain and has consistently been using the Rocky Mountain food sensitivity test in her practice. Because she gets amazing results and sees the clinical utility of that test, I'm really excited that she's going to be imparting her clinical pearls to all of you today. So today's webinar is being recorded. You will all receive a copy of that recording after the event is over. I also have uploaded some handouts for you all. If you just click on the handout tab, it's in that little window to the right that's got chat, Q&A, poll handouts. You can download a copy of the presentation. You can also download our healthcare practitioner bundle, which is all about the FST test, including an antigen list, some information just about IgGs, as well as the FST research repository, if any of you are interested, and our cross-reactivity document. So that's all there. You can go ahead and download that and refer to it as you need it. I also want to make sure that you know that today's webinar, we want it to be a little bit interactive. So although we can't hear you right now, everyone's muted, you can enter questions as Dr. Danielle is presenting under the Q&A section or the chat. And we will try to answer the questions as they come up. And in case we don't have time to get to everything, we will definitely follow up everyone's questions with an email afterwards. So I am happy to present Dr. Danielle Marchildon.
Hi, everyone. Thank you, Saroma, so much. So good afternoon or good morning, depending on where you guys are joining us from. I'm really excited about today. I love the the piece of speaking to colleagues and sharing clinical pearls. As Saroma said, I do run a lot of FST. I run a lot of testing in general. So I'm very familiar with Life Labs and Rocky Mountain as it is. As she mentioned, I do have 5 beautiful children, all of which were mistakes, which is why we have 5, but they turned out to be the best mistakes of our lives. I do co-own a clinic here in tiny Orangeville, Ontario. It's an integrative clinic. I'm very blessed with my colleagues, and I'm also very blessed with a very busy, full naturopathic practice. So today, let's talk about what our objectives are. So the very first thing we're going to talk about is when to use. So what signs and symptoms do you see in practice that might make you think of running a food sensitivity test? We're going to talk about results. So you run the test, you've got the results. Now what do we do with those? So we're going to look at the ranges and also use them to help us determine which foods are going to hit that elimination list. We're going to talk about clinical pearls. So I graduated CCNM in 2008, so I've been running this test, and I've seen the evolution of the test as well over the past 12 years. So there's been a lot of clinical pearls I've gained from there, and I'm really excited to share those with you. And of course, I'm going to give 3 case reviews where it was really hard to pick. I hope they showcase what I'm hoping to showcase. But yeah, and as Saroma said, if questions come up as we go along, I really like the idea of this being an engaged webinar, so ask away. Okay, so when do we consider the FST test? I listed sort of the main systems of the body where we're going to pick up clues as to when it's necessary or a really good idea to check. The first one is digestive. Of course, we're looking at food, so we are going to be always assessing the role of food intolerances in the digestive system. So none of us are strangers to the diagnosis of IBS, whether it's type C or D. Most of patients that come to see me, I find I'm a last resort for them, which I'm totally okay with. I'm just happy to be a resort. But often by the time a patient comes to see me, they've already had the scopes, they've had the stool samples, they either are or aren't on medication, whether that's a biologic or a methotrexate or, the various medications that are out there. As we know, IBS itself is a diagnosis of exclusion. I've really found that the food intolerance test is that missing piece of the puzzle for them. Most of my patients also, a lot of the family doctors in my office, when they have a patient with IBS, it's an immediate referral to their dietitian for the FODMAPs diet. So a lot of my patients have also already completed the FODMAPs diet with little to no improvement and also confusion upon reintroduction there. So IBS, of course, the autoimmune component that we can see in digestive, so whether that's Crohn's or colitis, any patient that walks in my door with an autoimmune disease, as we know, there is very likely going to be a hypervigilance on the end of their immune system there, where it's likely also going to be not all that happy with certain foods that come in. So Crohn's and colitis are on there. And GERD, if I see GERD, we're going to make sure there's no ulcer, H. pylori, that kind of thing. When it still persists, despite all that testing and treatment, we're certainly going to move forward with food sensitivity testing. Sequelae of poor elimination, I think what I meant by that, things like hemorrhoids, sinusitis, pruritus, ani, frequent fissures, right, where patients notice blood on wiping. Pruritus ani is actually a really common complaint that I've been seeing in practice, and I'm blown away at how removing the intolerance can certainly help that. We also, things like hemorrhoids and that, we want to improve elimination no matter what to move past that. In the skin, as we know, skin is a major elimination organ. As an ND, of course, we're going to approach a skin concern from inside out versus the more contemporary approach of outside in. So acne, eczema, psoriasis, which, there's an autoimmune component there as well. Idiopathic urticaria is also one that I just, often I get patients with idiopathic urticaria who have done the allergy test. Whether they've been able to remove an allergen or not, it still persists. It persists despite antihistamines. Antihistamines are just, going to take the edge off. Identifying food intolerances have been a game changer for several of my patients with the idiopathic urticaria. Joints, so unexplained joint pain. So you have a 30-year-old female who, despite no history of trauma or strain to the joint, notices that she's having knee pain. It's unexplained. They do an x-ray. There's no sign of arthritis, whether that's rheumatoid or osteo. I check for food sensitivity tests for sure, or food sensitivities. Also as an adjunctive treatment for pain relief. So one of my case reviews, you'll see a patient in chronic pain where this just became part of their treatment plan in terms of reducing sources of inflammation to help manage their pain. Upper airway, chronic sinusitis, a reactive airway, or postnasal drip. These patients are often just super mucousy. They're probably quite dehydrated as well. So of course you round out the treatment plan, but the FST test is certainly something I take into consideration there. And as we know, the immunocomplex that is formed in this reaction does cross blood-brain barriers. So I'll certainly consider it as well when there are chronic headaches, migraines. I've also seen it help reoccurring Bell's palsy in a few patients. So something else to think about. There is, of course, something, other things, metabolic. So if patients are having a hard time losing weight or unexplained weight gain, water retention, that's unexplained as well. Then there's, patients complain of brain fog, insomnia, and worsening of anxiety or depression. I don't think food sensitivities are a root cause for mental health issues. However, I'm a firm believer that they certainly don't help, and they can really endorse that cascade from a neurotransmitter standpoint. So I'll certainly consider it there as well. The last one too, that's just a one-off because I've just seen it being a game changer too many times, is unexplained infertility. Again, so you've got a couple who've been through the testing with the fertility clinic and they're being told, the RE saying, we don't know why you're not conceiving, we'll do that. And again, game changer. So the other thing I want to bring up here too, that on the requisition form, if you're familiar with it, there's a section there that asks if the patient is taking any immunosuppressant drugs, right? With the theory being that if your patient is taking an immunosuppressant drug, it's going to potentially lower baselines, so you're not going to get a true result. So what I do there with patients, I'll tell them if you're on treatment for an autoimmune disease, if you're taking treatment but you're still having symptoms, I'm very confident we're still going to catch the pattern. A lot of my patients are on a biologic, which doses infrequently, right? So these generally are not daily doses. So if they get an injection every Thursday, I'm going to get their blood taken the Thursday morning before the injection or the day before. So I'm just going to try and catch their blood when the dose of the immunosuppressant is at its lowest. To my knowledge, I have never not caught a pattern despite a patient being on immunosuppressants. So sure, we check that off, but timing of getting blood taken is something to consider there. When you are considering an FST, Rocky Mountain does offer 3 different panels. So there's a basic panel that has 120 different food antigens on it. There's an enhanced panel, which includes a lot of the superfoods. And then there's a vegetarian panel where you get into some more legumes and vegetables that wouldn't necessarily be part of a standard North American diet. You have to get a really good idea of the patient's diet to identify which plan they want. There is also, from a cost perspective, when you go from the basic to the enhanced, you're paying roughly about $100 more. So the general rule of thumb here is that if your patient is eating 4 or more of the added foods on the enhanced panel, it's worth their money to just run the enhanced panel. So, and I do know Saroma had mentioned there is a tear sheet, like Rocky Mountain can provide you with this, a stack of tear sheets where it's a questionnaire for the patient to identify if it's worth running the enhanced panel. I started using a tear sheet, but now I feel like I'm more familiar with the panels that I can get a better idea without them. But if you're just starting out and you're unsure, definitely take use of that form. The other thing I'll make note, because this is a tough lesson to learn for me, in the world of COVID, we are now emailing requisitions. On the requisition, Rocky Mountain requisition, on the second page, it says check off if you want to add an antigen to the basic panel to check it off. Every antigen the patient checks off, it's an additional $25. So Rocky Mountain called me a couple of weeks ago. I had emailed the requisition to a patient. I didn't tell her not to touch the requisition. So I typically would have said the requisition is filled out based on what has been paid for. Please do not fill out anything. I didn't mention it to that patient. She checked off 41 additional antigens, which would have been an additional like $1,025 or something. So Rocky Mountain was lovely. They called me and said, let's run the enhanced on her. Of course, I had to clear with the patient and get the extra payment. But so just take note in terms, I guess it's more of a clinical pro when you're emailing requisitions, because that would have been a hefty bill that I would have had to go after to collect, right? Yeah, so just a little clinical note there. Saroma, is there anything you want to add to that?
Yeah, I don't think I included that little checklist, but for anyone that's interested, it comes in a TerraPad. It's called Which RMA FST Panel is Right for You? And what it is, it's just a one-pager, and it's got all the different foods from the different food categories listed. They're all foods from the enhanced panel. So the idea is you check off the different foods on the different categories, and if the patient checks off 4 or more, it's advised to just go ahead and run the enhanced as opposed to the vegetarian or the basic. And also, Dr. Danielle, I'm not sure if you knew, the vegetarian panel is actually all the foods from the enhanced. It just doesn't have meat and seafood, but it does have all the different additional like quinoa and the different legumes that are on the enhanced. It just doesn't have meat and seafood.
Okay. Excellent. Okay, so you have a patient sitting in front of you. You're fairly certain you want to run the FST. So you've sent them to the lab, you've gotten results, and now what? So let's talk about ranges. So, and I've been doing this test for 12 years. So up at before, what year was it? 2015, Saroma, that Rocky Mountain switched over?
You know what? I cannot remember. You mean when we switched the test?
Yeah, to in-house testing. I think it was 2015. I think it was 2015. So up until then, I was getting, it was a finger prick. I was collecting that sample in office and we were mailing it out west, and then it was third-partied over to US Biotech. Those results were presented much differently than they are now. It was also, that test, US Biotech was only checking roughly 82 to 84 antigens, I think, and it was presented with a bar graph. So then Rocky Mountain then decided to switch it to an in-house test and presented differently, where instead of bar graphs, we were given a quantitative number next to each food, and the antigen list increased from 82 to 84, upwards of 120. For the first around year of Rocky Mountain doing the test, the cutoff for all food antigens was 30. So if the result was over 30, that was an intolerance. Within about a year of running the test, the lab did change some antigen levels based on, they were made to reflect common results, right? So we were looking for outliers here. So if a large majority of patients had a number over 30 for casein, then they were going to raise the bar there so that we were, again, catching the antigens. This is following in line with a lot of developing lab ranges in terms of what we see as common in the population is potentially normal, right? I don't necessarily adhere to this as a rule for some of the foods. I still look at, when I'm presenting results, I'm still looking at 30 as a cutoff, but you'll see as we go along how I then put numbers into context. So, a good example is that if a patient is having, let's say, has chronic sinusitis and is having 5 coffees a day and there's 2 cream in 3 to 5 coffees a day, there's 2 cream in that coffee, and her casein or cow's milk comes back at like an 80. It's now yellow. It's going to be considered a borderline. I'm still going to have her eliminate dairy there because even though it's not red in terms of Rocky Mountain's ranges, I just know that she's going to benefit from switching that cream out of her coffee, despite it being a borderline. But we're definitely going to get more into that. Okay. So this is just direct snapshot from a set of results. So when you're looking at the results, normal are green, yellow is borderline, the red is elevated. Majority of foods fit into the category. 0 to 23 is considered a tolerated food. 24 to 30 is generally borderline, and red range would be 31 and up. It does list here the foods that have the antigen, the range changes. The most notably here, the ones that will affect your patients the most is going to be, the most common that we see. So corn, egg white, gliadin, cow's milk, pea, wheat, and brewer's yeast. These are the ones that I will put into context based on intake. So if they eat it every day, so again, like I said, with cow's milk, the red range is 115 and up. If I have a patient who has dairy daily, but in their mind it's a very small, I just put milk in my tea a couple times a day, but their dairy level is 110, I'm still going to pull dairy, right? So I don't adhere to the lab ranges per se. The key point, the take-home point, is that everything has to be put into context with that patient. So I'm just waiting for that next thing. So the other thing we have to talk about is the potential for cross reactions. They do commonly come into play. So this is when across a group of foods there is a protein that is so common that we see. So I have lots of patients. Plum pops up all the time. Patients are like, I have like 1 plum a year. That's going to be a cross reaction, right? Patients always say, I don't know, sunflowers are bad. I'm trying to look at here to come up with something. Oh, walnuts is another one. I hate walnuts. I don't eat walnuts. Well, it's a cross reaction. And when you look in that nut, seeds, and legumes category, you're going to see generally if they have this certain cross reaction, there's going to be several that light up there. And you're going to be able to find one or two of them the patient does eat a lot of. So informing them of the cross reaction is really important, because for skeptics, when they say, my walnut was high, I don't even eat walnuts. Well, you want to fully inform them there so that they can fully comprehend why the results say what they want, or what they are saying. So again, in this category, you've got storage proteins. This comes in the form. These are albumin storage proteins, so prolammin, and then 2 different forms of cupin. What else do we have? These are the birch, ragweed, timothy, and mugwort. You can see these are the profilins, right? There's also, the oral allergy syndrome can come in here as well. In this one, two that I see often, frequently, with potato and celery, they often come hand in hand. It's a good example. And the last one are lipid transfer proteins, and then the latex. So, have a look at these before, when you get into it, because it can just help explain, when you get that patient saying, I don't eat any of these. You want to be familiar with some of the cross reactions, again, to fully inform. I see it take place most through the nuts, seeds, and legumes category, in terms of just, it often can light up like a Christmas tree. So identifying where those are coming in can be helpful. Instead of eliminating 100% all of them, things like Nutella for the hazelnut or peanut butter are big in terms of cross reactions, for sure. Okay. So here's a sample. This is just a snapshot of sample of results. So these are just the first 3 categories. RNA does present results. When you get a set of results, you're going to see they're presented in 2 different ways. The first way is grouped by food, like food groups. The second one is just a list of their tolerant or intolerant food, borderline, and tolerant food. I don't even print that list for patients. One, we are mindful of paper use in our clinic. It's sort of one of our missions. But 2, I find when they look at the list listed for tolerances, borderline, and intolerant foods, it's so hard to wrap your head around. It's a random list of food. They're way more overwhelmed when they first see that list than when it's broken down by food groups. So I just show them the food group set of results. It keeps it clean. I find that they leave my office feeling much less overwhelmed than if they get the list of when it's broken down based on intolerant food.
Dr. Danielle, I've got a question for you. So Carly Cherio on the cross-reactivities, she wanted to know, do you still avoid these cross-reactive foods? So let's say something comes up. So let's say that when you had a plum coming up, it's under the profilins category. It's a birch pollen cross-reactivity. So what would you do in that case?
The first thing I'll ask is, what is your intake of plum? I think almost 100% of my patients either say none or like 1 to 2 a year, right? So first I look at their intake. If she's like, oh, I eat dried plums, whatever, all the time, then we're going to eliminate it. If she's having 1 to 2 a year but suffers from IBS constipation every single day, eliminating plum, for example, is not going to make a difference. So I don't, we recognize it, but then it leaves the topic of conversation. Same in that nuts, seeds, and legumes category. I look at what role does this play in your diet. Being mindful of, let's say of the nuts and seeds, they don't eat walnuts, but they do eat a lot of almonds. So I say, well, we want to stop almonds, but I don't necessarily want them to just start eating a lot of walnuts, right? So just being mindful that a cross-reaction exists. You don't need to be reading labels for these. It doesn't have to be a strict elimination. You just don't want them to go from a handful of almonds a day to a handful of walnuts, right? But yeah, it's all about context with the patient.
Awesome. Thank you.
No problem. Okay, so on the sample results, you'll see here the numbers are listed next to each food. Yellow is borderline, red is intolerant, the green means they tolerate the food completely. This is also an example of enhanced panel. So because I can see the buffalo sheep is in there, the spelt malt is in there as well. Those are all part of the enhanced panel. Of course, on this set of results, things that stand out to me is going to be the dairy, the egg whites, gluten for sure. Oh no, I was going to bring something up, but we're going through that in the clinical pearls. So, and then gluten-free grains obviously they're all good to go. So let's put this into more applicable stuff here. So, like I said before, I tend to always show the results that are presented by the grouped foods instead of listing it between the three. It's just easier for the patient to process. The other thing I want to talk about is borderline foods, because what that means to me, when something's yellow, what that means to me is that the amount they're currently taking in is okay, but we don't want to drive that as a replacement, right? So one I see often would be, so gluten is an issue, so gliadin is elevated and corn is yellow. As you know, corn makes up a really large part of the gluten-free market. So in this case, I would instruct the patient that, by no means are we eliminating corn from the diet, but try to stick more into the rice-based gluten-free world over the corn-focused gluten-free world. Or another one is dairy is a intolerance, and oat is borderline. This is where we wouldn't want to switch over to oat-based dairy-free products, right? That we would want to try and stick to coconut or, barring no other intolerances to cashew or almond or soy, whatever, we would stay there. Now, depending on the results, because I've seen some really hard, challenging results, sometimes we don't even look at borderline foods until they get 6 weeks into their elimination diet, where I can take a look at their diet diary and make sure, I'll explain that after. I'm getting ahead of myself. I always explain to the patient that the results are dynamic and they always require looking at, putting them into context. So I really, some patients want to run the test and they just want me to fire off the results, which I will, absolutely no problem. It always comes back with 50 questions, right? So, the patient really does need the interpretation from us to make it workable. Because sometimes, a lot of the time, I'm shortlisting that while results can be horrible or horrifying to some patients, I'm going to shortlist it to make sure that we're having the most successful outcome, but also making sure it's still sustainable. It's not black and white. These are not binary, and you want the patient to understand that, especially ones that tend towards, there are patients that will go super hard, and that's not necessarily, it can be all consuming. So you really want to approach the conversation with flexibility and fluidity while keeping in mind successful outcome. I always start, and I also, go ahead. Yep.
Sorry, Dr. Danielle, I was going to suggest to some of our attendees out there, if anyone has any or had any strange combinations of foods come up, or you had a tricky patient or something that you didn't quite understand, go ahead and put that in the chat and we'll ask Dr. Danielle as she's going through. So just think of anyone that you've seen or any report that you've had that comes back and you're sort of scratching your head or wondering what to do, please go ahead and put that in the chat.
Yes, absolutely. The other thing I'll mention too, what I meant to mention with cross reactions is that I know when the test had initially switched over to in-house testing, and I spent a couple of conversations, I had a couple with Dr. Klassen, who was so helpful at helping me wrap my head around the new presentation, but also keeping note that the idea of cross reactions is really a developing concept. That the lab has done a really great job at identifying a really good foundation of cross reactions, but that if you as a practitioner start to pick up patterns of things, that the lab is always give the lab a call and say, I just want to let you know that I'm noticing, and they'll dig and they'll see if there's something there. So that's just something to remember too. Okay. List intolerances and then short list if to help with sustainability if that's applicable. Remember, if a food is elevated and the patient says, I don't even eat that, it's usually a cross reaction. So that's a good reminder to have that conversation, that cross reactions do certainly happen. The other thing to keep in mind too is that patients come and they've been dairy free for a year, and they want me to test to see if that's necessary, if they are dairy intolerant, and if they can eat it. So as you know, we have to be eating the food to see the reaction. So at that point, I say to them, I get history. So what was happening before the dairy elimination? What happened after the dairy elimination? Have you tried reintroducing it since? All of those questions are important. If at the end of that they still want to know, we've got to bring dairy back in. And I have them bring it back in at 4 weeks is my marker. Some patients make it the 4 weeks. Other patients go, look, I've done it for 6 days. I'm so sick. And at that point we say, okay, you have an intolerance to dairy. Like, why are you putting yourself through that? So again, once they eliminate the food with the history of an intolerance, it is going to start to reduce their IgG complexes in their blood. So you're not going to get a baseline if they have recently or not recently eliminated it. The half-life of IgG, I think, is about 2 weeks. So if they've only been dairy-free for a week, still run the test, right? We're still going to catch it. But if it's been a while, you're either going to want to reintroduce or tell them it's just not worth it. I have retested, not often, but I have retested on patients who just wanted to see. Saroma, my video went away.
It might just be bandwidth. So we can hear you totally fine though. So just carry on.
Oh, good. Okay. Okay.
Yes.
Yeah, so casein and cow's milk, those complexes, they do take a long time to mobilize and break down. So even though a patient, say, has been dairy-free for 3 to 6 months, when we rerun, we'll see a reduction, but we're not necessarily going to see a normalization. Or we may never get numbers right down below the 30 mark either. So something to keep in mind. Okay. There is a fine line between positive outcome and sustainability of the elimination period. So, and this was something I certainly have learned over the 12 years, that you can be more flexible with based off of how much they're getting in their diet and what kind of a role they may be playing in their symptom picture, signs or symptom picture. So really be mindful of that. You know, you want to sit, every time I get a set of results, before I even call the patient to come in, I'm comparing the results to their diet recall, to their symptom picture, and I'm really looking at how to make this sustainable for them. For some patients, a more challenging elimination serves them in more ways than one, in terms of learning how to eat a whole foods diet, cooking from scratch, staying away from processed foods. But you'll learn to read your patient and know what they're capable of. You're always going to be pushing them outside of their comfort zone, but with proper support and full, there's an empowerment piece and an education piece. My patients tend to do really, really well. And again, always put patient into context with how much of the food they eat and what their symptom picture is. Be flexible as a practitioner. You will know, some patients, you can let them go for 12 weeks and they're going to be fine. Other patients, you're like, okay, so let's check in a week and see how you're doing. I don't charge for a follow-up visit. I say, shoot me an email in a week and let me know. Because if I can just help, words of encouragement, but remember how inflamed you are, that's just what they need, and I'm more than happy to provide that. Some patients who are willing to start, I don't tell anyone, this doesn't start tomorrow. I want you to take a week, 2 weeks. I mean, right now I'm saying Christmas is coming, so maybe in the new year, wrap your head around it. Start building meal ideas. We have a nutritionist here who does the meal planning and stuff for me when needed. So she's very familiar. I've got her very familiar with this test, and she builds meal plans for the patients that are really, really struggling, grocery lists, all of that. She is my most valuable team member here in terms of providing that for my patients. Again, being transparent, fully educating the patient. I tell patients that I tell them about the ranges, how we're looking for outliers here, but I'm bringing them in. My ranges are going to be a little bit tighter than what the lab says for some of the foods. I want them to fully understand, and when they do, they have higher compliance. In terms of reintroduction, so depending on the patient, it's not very often where I'm like, look, you're in for a lifetime of whatever, no dairy, no egg whites, and no gluten. That does not come out of my mouth. They're in, every patient I start with a 12-week elimination. That's the starting point. We eliminate, we do some gut healing, and then we're going to talk about process of reintroduction. I remember being in the 4th year, and when we reintroduced, it was like, well, have a serving of dairy for the next, 5 to 7 days and see how you feel. But that's not my end goal for my patient, right? So why am I giving them a glass of milk every day for 5 to 7 days when, one, at this point, they have no interest in having a glass of milk every day for 5 to 7 days. They might just want to know that they can have hard cheese, for example, or know that they can have pizza once a week. So that's where we start. So the idea of starting where you want to finish. The idea here is that they are going to reintroduce at a rate that keeps their inflammatory reactions down. It brings back flexibility. You don't want to be the vegan at the party. People say that to me all the time. So those first 12 weeks are where you're really focused. After that, you're going to learn a new tolerance level for the foods that you previously had completely eliminated. Again, large majority of my adult patients are feeling so good at the end of 12 weeks that they might have, I have patients say, I just want to grab my old, once a week, I want to have whatever drink from Starbucks. Okay, try it. Let's try it and see how you do. Most patients do really well on reintroduction. We talk about there being a fine line, though, that you might have pizza one night and go, that was awesome, I'm good. And then next thing you know, you're back at square one. So just always checking in with self about tolerance levels as you reintroduce. We'll also quickly here talk about replacement effects. So the idea that it's not so much the elimination of a food that makes you feel better, but the introduction of a food that your body does better off of. I am totally aware of replacement effect. I am happy that it exists as a concept. I just find, if that's where you want to approach the patient from is to talk about replacement effect, I just find, because I have tried that, especially when the test was switching over as well. There was a time where we didn't have as much access to it. Patients, I had a harder time motivating them to do it, to try going a month. Instead of drinking dairy milk, let's bring in whatever milk replacement. I do recognize that for some patients, that's certainly where we do feel better. Our body will feel better on certain foods. But this is a really great way to help the patient learn that, right? That we're not it's harder to get them to replace all the foods that we know aren't necessarily pro-health. That from a dietary standpoint, it could be better. This is a great starting point, and it gives them more motivation because they've got a paper in front of them that says their body is not tolerating certain foods. Okay, next clinical pearl. So ideal elimination period is for 12 weeks. That's how I do it. I believe in terms of research that it takes at least 12 weeks before we start to see a significant enough reduction of these immune complexes to see improvement in the patient's health. During the elimination, I will always do gut healing. So I have patients come in all the time who have either seen another ND or they've already experimented. Now, often they haven't eliminated, they'll say, I've tried dairy and gluten-free for a month. It made no difference. Well, they may just have to do it longer. It may be more than dairy and gluten, which is why they didn't have a good experience. Or they've done the test with another ND, they did this, 12-week or even more elimination, and they felt no different. I really do find that there has to be some sort of and sorry, in that case, they just did the elimination. There was no supplements. And I believe that the conversation was, well, let's just see what food's doing alone, right? But we know that there's going to be, on a cellular level, the gut lining, there is going to be some issues there, and even microbiome, right? Like, it will be very disturbed if we don't replenish microbiome and look at intestinal permeability. They're not going to have the improvement that we'd like them to see. Now, patients ask me all the time, what happens at the end of 12 weeks? Do I retest? No, I don't. I think based on their improvement, some patients that say, look, we're just on the cusp of that improvement. Let's go another 6 weeks and see how you do. Most patients I'm able to start reintroducing at 12 weeks. Down the road, though, so I also, again, being in practice for 12 years, I've seen patients now go from, university into marriage, into having their first baby, divorces, or a really awful flu, anything that would create, because, we talk about the idea of epigenetic change. So something happening, whether it's a major physical or emotional trauma, where we can see that epigenetic shift, and the immune system, when patients grow into and out of allergies, the same thing's going to happen with food intolerances. Women, of course, being at high, they have more opportunities generally because of giving birth to babies. Menopause certainly presents more opportunities for an epigenetic shift. So, if I had a patient when she was 24 who had some food intolerances, and then she had a baby and noticed that after the baby, she can no longer tolerate eggs, I'm going to retest. I'm going to retest and see what her immune system is doing now. I do have patients who just say, no, I just want to retest. After 12 weeks, I'm going to pay the money. I'm just going to retest. And so I do. And generally what we'll see there are reductions of their IgG complexes, as expected. And some of them I'm like, wow, that number is really, really good. So they're more confident in reintroducing those foods when they've done that. It's not retesting after 12 weeks is not something I generally make practice of. Okay, so another question, why are some food antigens so common? So here in Orangeville, there's a Facebook Orangeville Q&A, and a patient had posted her results on the Orangeville Q&A, and people had responded saying, I had a test, and I also had dairy and egg whites, right? And then a lot of comments came saying everyone that does that test has dairy and egg whites. I actually don't see that. I had two today that didn't have, their dairy was so low, they actually don't have dairy intolerances. So number one, not everyone is intolerant to dairy. In terms of common antigens, we have to look at the foods that are common. So this is dairy, gluten, corn, rice, egg whites. These are foods that we have, in North America, have really messed with in terms of genetic modification. But I think our immune systems are having a harder time identifying these food proteins. I think, if we look at it an evolutionary kind of standpoint too, that we're still looking for dairy as it was, 60 years ago. I've had way too many patients tell me that when they show up in Europe for a vacation and they eat all the pasta and they eat all the dairy, they have no bloating, there's no pain, their skin is fine, they sleep well. There's something to be said for that, but I think we are at a disadvantage eating North American food, sadly, and that our immune systems are having a hard time catching up. And so I explain that to patients as well, that, you're going to see commonalities, but they're the food, when you look at that group of foods that are so common, it makes perfect sense. Have I ever tested someone who has no food intolerances? Yes, all food is foreign to an extent to the body, right? So we're going to see IgG elevations to a lot of things, whether or not they're to a point where it's going to create an inflammatory cascade or an inflammatory reaction is another. I have seen a couple of test results where there weren't any. As NDs, we're in a business of unwellness. So patients who come to see us generally don't feel great. And I don't run tests on people who feel great, unless they, they'll ask, and they will. I'm sure some of you know that they will say, no, I still want to check because my brother's sister's daughter's nephew had some, and I want to check. But again, we'll see. No, you don't have much here. The other question is whether or not the only way to rule out food intolerances is to do an elimination diet. There is a lot of value in doing an elimination diet. It's not that I don't disregard that as being a valid way of identifying which foods you tolerate or not. I find patients aren't very good at it. I will give patients the option. I also find reintroduction is such a great, like a blurry line. If I could sit with them every single day on the reintroduction and they journal that and they, diet diary, and they journal it properly, we can come to some sort of conclusion. I don't find they're all that great at it. And an elimination diet, we're pulling a lot of foods out, so we've got to be picky. I would never tell someone to pull out pea protein, for example, out of an elimination diet. Inevitably, they're going to get some, probably. What if that's an intolerance, right? They're not going to see the benefit, and they won't know moving forward that pea is an issue. So, elimination diet, again, is still very valuable for the common things. I have a conversation with my patients. The majority of them choose the test. So, what else? Okay, so now we're into case reviews, I believe. Okay. So this patient, 14-year-old male, chief concern of severe eczema. His hands, upper and lower legs were affected. There was a lot of excoriation, a very severe presentation of eczema. He also suffered from severe OCD, very ritualistic, so washing of hands, questioning family members about their hygiene, certainly was worsened from COVID. He had an allergy test.
Sorry, Dr. Danielle, sorry, I apologize for cutting in. We just have two questions just on the last clinical pearls that you just finished, so I thought I'd bring these up now so we can just wrap that up before going into the case studies. So Dr. Carley is still asking about the cross-reactive foods. Do you avoid these cross-reactive foods if they come up? And let's say the patient is not eating that, but maybe they're eating something else on a regular basis, maybe within that cross-reactive bucket. So as an example, everyone, I'll just give you an example, 1 second. So like plums, for example, like they are prolifin, which means that profilin, sorry. So if they're eating something else under that category, what would you do with that, Dr. Danielle?
Like whether I would tell them to avoid plums?
No, if they're eating maybe something else within that profilin bucket and they're not eating plums. Sure. So how would you handle that?
Yeah, sure. So in the cross-reaction group, what you want to try to identify is in that cross-reaction, which food is being eaten in a higher amount that's driving that cross-reaction. So we know that eliminating plum for this patient is not going to, that plum is elevated because they're eating something else that the body is identifying similar to plum. So you would want to try it, and sometimes it's really easy, and sometimes it's just not, it's not that clear, where you're going to look at the higher numbered ones, pea being a really big one. You want to pull those ones out. So again, sometimes based on, so you would just ask them, what's your intake of almonds, walnuts, pea, peanut, hazelnut? Because you'll find that it's not often patients like, oh, I eat an array of nuts, right? That we often find the ones that we like and we sit in that pocket. So if you can identify it, great. That's the one. That's what's driving that cross reaction. So that's the one you want to pull. If it is a case of, well, I eat a little bit of all of it, then you want to pull the ones that have the highest reaction to that food.
Got it. And just so that everyone here, we didn't have that full list on the presentation, but plum, for example, is under the birch pollen profilin group. So the things that are cross-reactive with that are almonds, apples, carrots, celery, cherry, hazelnut, etc. And Dr. Matthew Pace is asking, Are outliers consistently being updated? I am seeing barley, kola nut, and ginkgo coming up as elevated with all my patients. Yeah. I'm not sure what you quite mean by updated, Dr. Matthew.
Well, I think he's asking if we're seeing, because, you know, for example, I have to pull up the kola nut range. I think he's saying that he's seeing commonalities across results so that are coming up as red, and that whether or not, because most commonly he's seeing these with a lot of patients, that he's wondering if the antigen range should be dropped because of that.
Possibly.
And I think that's a really good question. Like, that's a really good question to call Dr. Klassen and have that discussion, because he will go into that. Like, I think that's worthy of a phone call.
Yeah. Also, one of the things that I've learned from Dr. Klassen is, and by the way, Dr. Matthew, we do have, and we didn't post that in the documents, but we also do have a reference range sheet that we can provide to you, which gives all the normal ranges for every single food on this list. And kola nut, by the way, is something that's commonly found as an additive in a lot of different foods. I don't know about you, Dr. Danielle, but I've been told that it's not really something necessarily that they have to eliminate, but it's coming up because it's in so many different foods as like a colorant. So that's why that may be coming up. But as far as changing the reference ranges go, we are not making continual changes to the ranges. So that report cover that Dr. Danielle was referring to, that changed some of what all that happened was on those specific foods, like like gliadin, cow's milk, some of the common ones, the normal range was widened. So basically, the normal now is 0 to 30, and it starts becoming yellow beyond from 31 to 54, or depending on what the range is listed. And that's because it's all based on reactivities on the population. So we look at different people, we measure their IgGs, and we start taking note as to when they start feeling reactions or seeing these reactivities occur. And that tends to happen in the 75th percentile, which coincides with the result of 30. So that's where that update came into place. And Dr. Christina is asking, peas, I understand you are testing green peas. That's correct. Would you agree to allow yellow peas? Dr. Danielle, like if a patient's eating comes up, would they be allowed to eat yellow peas? And then also mushrooms, if it is positive, are we removing all types of mushrooms, or is it just button mushrooms?
So in terms of the peas, I mean, again, it's a matter of intake, right? So people who come up with high amounts of the green pea protein, you know, they're often, you know, I have a lot of patients that are a big fan of like the Vega line of protein powder, for example, which is mostly pea. When we talk about, and of course, as you know, when you go into the dairy-free world or the vegan world, we're going to see pea protein pop up in a lot of these products. That's where I'm going to get them to focus their elimination. If they end up having, for example, like you said, yellow peas or split pea soup once, you know, in a blue moon, that is not going to make or break their improvement. That with green pea, it's often because their intake includes pea protein somewhere in a high amount. It's not often I see, you know, a pea protein level that is worth 100% elimination where that patient isn't having a pea protein source every single day, if not twice a day. So again, that's that context piece. I believe I remember talking to Dr. Klassen about the pea years ago, and at that time, do you know, Saroma?
Yeah.
Sort of.
So I'll share this with you all as well. I have a really big, RMA has a giant guide called the taxonomy chart. And that's really helpful because when you get this question about the peas, this chart basically shows you the family of the different foods so that you get an understanding of what's in that group. So because they are part of the same species Okay, so you've got species, genus, subtribe, tribe, and subfamily. So all of the foods that, if you're just looking at the species and among the same genus, these are very similar in structure. So peas, for example, are part of the bean family, which includes beans, carobs, chickpeas, garbanzos, lentils, peas, soybeans, peanuts even. These are all very similar in structure. So again, with what Dr. Danielle says, you have to look at how much they're eating and where they're seeing that food, and also really being cognizant of ingredients. So looking at their protein powders or other foods that they're eating. Peas can be in a lot of things.
They're like corn.
Yeah, exactly. So I think a lot of the times people just assume that when you say peas, you're talking about like green peas that's on a plate. But that's not necessarily the case with our diet right now. We're seeing peas in pastas, in different types of foods. So you just have to, I guess, start looking at ingredients more. But to answer your question, Christina, if peas are really positive, I believe, and they're eating it quite a lot, I don't think you would necessarily want to recommend yellow peas because it's in the same species.
Right. Yeah, and I remember that's why they didn't, I remember Dr. Classen saying it's why they didn't say green pea. They didn't list the antigen as green pea for that reason as well, right? Like, it is more of a general, I have a lot of patients who go, oh, so I can't have chickpea? No, you can have chickpea, right? It's the pea family that you don't want, right?
Mm-hmm.
So, yeah.
There you go. Sorry, you can continue.
That's okay. Okay, so case review number 1, like I said, 14-year-old male, chief concern of severe eczema. OCD wasn't the chief concern. He had just started talk therapy, hadn't started medication yet. However, they brought him to me for his skin. No known allergies. He was not on any medications or supplements at the time. No relevant family medical history. Parents, I put this because this, has to be put into context. His parents are divorced. Spends his time between the two homes, and his mom had just given birth to a new child, which is going to play out when we expect certain, dietary changes for this patient. So here's the first set of his results. So things that stand out here obviously are going to be the dairy and gluten. I'll make note too in the grain category, right? So gliadin is checking for gluten. The rest of the grains in this category, what we are checking is their identifiable protein. So we're not checking the gluten in barley and wheat. We are checking for the barley-specific protein and the wheat-specific protein. So where this becomes confusing for some patients, so for example, his mom could look at these results, for example, and go, okay, so he's gluten intolerant. He can't have durum wheat or barley, but wheat's only borderline, so he could have a little bit of wheat, right? So you have to explain that because gliadin is red, that wipes out all the grains in that category with the exception of oat, right? So oat by definition does not contain gluten. The issue, of course, is that a lot of oat products have a massive cross-contamination. So he can still have oats, but they've got to say gluten-free on the bag. Okay, so yes, on this set of results, like I said, we currently are looking at dairy and gluten. On his fruits category, raspberries there, it's just at a 30. While that is red, that's a good example of something that I would ask about intake of. This is white potato. It's come up. His fish and seafood are fine. Meat are all fine, as they typically are. Herbs and spices, he's got some borderlines there. The one I did ask about here was mustard. He only ate it about twice a month. So I wasn't, and mustard's not something that's going to generally increase with what we're looking at as a dairy and gluten elimination. His nuts, seeds, and legumes. So here's a good example. We're picking up cross reactions here, right? So cashew, pistachio, sunflower, pea, kidney bean, hazelnut, and peanut. in this case, I asked about cashew intake. He actually was at his dad's house. They were just starting. He had been on cashew milk for the past month. So this is where I focused my elimination for him in that case. The rest, I didn't really have to worry about. And this is where, again, I'm dealing with a 14-year-old boy. He's not all that keen on being in front of me to begin with. You don't want to sit there and list with him, oh, but look at your pistachio, your sunflower. You are going to overwhelm. You want to make sure that the communication is very clear and concise, but specific to your plan, right? So here's what we did. Again, I had to be flexible with elimination because patient did split his time. His dad's house looked like it was going to be a lot easier compared to his mom. While at dad's, so raspberry, it was his favorite fruit. So we did pull it. He also, would definitely eat potatoes in the form of French fries. So while at dad's, we had him completely eliminate dairy, gluten, raspberry, potatoes, and cashews. And while at mom's, the best we could do was to advocate to reduce his intake. I put him on a probiotic, a gut healing formula, and I also used a compounded cream for his skin using cyanocobalamin. And the NAC, 500 milligrams twice a day with meals, I weaned him onto that. So we started with 500, and that was for his OCD, which, is not what we're talking about today. At the 12-week follow-up, I was in communication with his stepmom through the entire 12 weeks. She would let me know how he was doing, and then I would write an email back, and she was reading my emails to him as a means of encouraging, because he was doing such a good job. So at 12 weeks, presented to my clinic, the skin on his legs was completely cleared. He required the compounded formula for the first 4 weeks of elimination, but then didn't require it anymore. His hands were still affected, but he was still washing his hands frequently, so that's something that we're up against. Stepmom noted that he was much less irritable. He was eating, his palate expanded, and he started making his own food at his mom's house because he could recognize the difference between how he felt at his dad's house compared to how he felt at his mom's house. The OCD wasn't as prevalent as well, but it was still a work. He was still doing therapy, and they were starting to note some improvement in some of the areas. So this was a good example of where, he did want to do some reintroduction. Mostly he wanted to see if he could have pizza at school. His stepmom used to, since COVID had started, his stepmom was bringing him pizza on Fridays, I guess, which I didn't know we could do, but she did anyhow. And as far at last checkup, which was roughly about a month ago, he was eating pizza once a week, but he noticed that when he pushed his elimination, so when he started going back to previous dietary habits, his skin started to get worse again. So he will quickly, when he notices a flare, he quickly tightens it back up, and he's communicating, telling mom and dad, I need to get more of this or this in the fridge because I need to. So it was a really good, certainly clinically successful instance. Oops. Okay.
Dr. Danielle, before you get into the second case study, I just have two questions that came up from the last one. So Dr. Catherine Sully is asking, I kind of have two opposite ends of the spectrum here, two different questions. So Dr. Catherine Sully is asking, have you seen patients that show no food reactions that aren't mounting an immune response due to low immune function, meaning that she's getting a lab result for FST and there's very low or nothing coming up on her FST result, but it's due to low immune function? And then I have Dr. Anna Nazari asking kind of the opposite question. How do you manage an elimination diet when tons of food's coming up and showing as reactive? So one, nothing due to low immune, and the other is the opposite.
No, I haven't. I think because if someone has low immune function, they may not be a great candidate for this test anyway. So, getting that initial intake on the patient and knowing where their health stands before recommending a test that would check in on, that would assume an active immune system, would be really important. I can't think of a time where I got a set of results and I was scratching my head going, this doesn't make any sense. Doesn't to say it doesn't happen, but my own personal experience, no. In terms of a really extensive set of results, because I've seen it, I don't see it frequently. I just had mom and daughter actually got a set of results today that are really, really going to be difficult to navigate. Again, that becomes more of a trial and error, putting all the foods into context. Starting for some of these patients, you might want to start with, okay, let's just get dairy and eggs out to start. Don't expect them to be able to take out all the major groups of a North American diet all at once, especially if they're a new mom or it's a child or like whatever it is, right? You want to make sure that you set them up for success. So your plan or your protocol will change based on what's going to really help them. Again, I've gotten really good over the years of shortlisting food based off of their intake. So you really want to look at, in fact, a lot of the really severe ones I've seen are in a pediatric population who are mostly eating, they have milk when they wake up, they have gluten all day long, goldfish, bread, yogurt once a day, cheese and crackers for snack. You're going to focus on the dairy and gluten there because you're going to see a lot of improvement just with that kind of elimination, right? So if they also have a really severe egg white intolerance, but they're only eating eggs 1 to 2 times a week, eliminating that and making life really hard on both parent and child isn't going to match the, you're not going to see an insanely higher improvement or larger improvement by making life harder on them. So it really is, and the more you run the test and the more you experience it with patients, you're going to be more comfortable shortlisting it. There's no algorithm, there's no formula because every patient's diet is so different. You just need to get a really good handle on, because in clinic when I'm considering an FST, I'm getting a diet recall, but after that I get them to tell me about their intake of the more highly common food intolerances. So what is your dairy, your gluten, your eggs, what kind of nuts do you eat, right? Pea protein, is that playing a role? Like I look at corn and rice, I look at where those are all playing a role so that when I get the results, I have that information to put it into context. Good.
Great, thank you.
All right, you're welcome. So case review number 2, the 16-year-old female, chief concern of ulcerative colitis. She also has a history of gastric ulcers. She's tall, lean, incredibly pale, very quiet and shy. She is on Remicade every 7 weeks. She is on Zoloft because of anxiety, pantoprazole for the history of gastric ulcers, Restoralax to keep her gut moving, vitamin D and iron because she had deficiencies of both. However, those are the 2 things that she was not consistent with. Despite her medication, she was still experiencing constipation, abdominal pain, bloating, and significantly low energy. Hemoglobin, hematocrit, and RBC counts are all low. White blood cells and neutrophils were elevated at the time I saw her. Her ferritin was 5, her D was 56. She did advocate for herself to come see me because even though her rheumatologist told her that food was not playing a role in her health, she felt differently and really wanted to come in. We did have the conversation that vitamin D and iron will not be helped, like the fact that she was taking them inconsistently and that her levels were what they were at, that was not helping her overall picture. However, we did run her FST. So this is her first set of results. So again, notably, you can see that casein's an issue, cow's milk, goat and sheep, egg white are high. Her barley came back red. Her gluten, while it's over 30, is at 45, so she's not an outlier here. And then her wheat, her oat, and her wheat bran also were considered borderline. And her rice came up as an intolerance. Orange was her only fruit. She was eating them pretty infrequent. Well, she was definitely eating them, but it wasn't like she was not daily. She had a white potato as well, also her quote-unquote favorite vegetable. Meat protein's nice and low. Herbs and spices are nice and low. Again, here we go into the nuts, seeds, and legumes category, right? So the red there, cashew, pistachio, sunflower, hazelnut, and peanut. And then borderline almond, white bean, Brazil nut, and pea. Her brewer's yeast was at a 29, but again, at 16, I wasn't focusing on brewer's yeast. It just did. I guess my eyes are trained to see, I guess, the 20, 24 and up, my eyes are looking at. So we were eliminating dairy, egg whites, barley, potato, rice, and oranges. She only ate eggs and white potato. Oh, I thought she was the one that white was her, or potato was her favorite veg. Her parents expected her to, not because she liked them, so this was an easy elimination. But the other thing, too, is that as you go through the intolerances, I'm actually making note on their results as we go through, because they'll say, oh, that's fine, I don't like that anyways. You use that when you're explaining the elimination period, because there's a difference between saying, okay, I want you to take out at 100% dairy, egg whites, barley, potato, rice, and oranges. Instead, the conversation goes, I want you to eliminate dairy, barley, rice, and oranges. The eggs and white potato are an easy elimination because you don't like them anyways. So it takes the burden off of like, okay, and then, oh yeah, I don't even like them, so it's easy to eliminate, right? I was mindful of her nuts, seeds, and legumes in terms of where she would get exposure to them. So she wasn't a big snacker on nuts, so I just didn't want her to become one. She thought cashew milk might be one that she would like to try, but I said, well, ideally not. And she did like peanut butter and Nutella, so those both were coming out. Her gluten was considered borderline, and at 45, I'm looking at more of a stricter elimination of gluten when we get over closer towards the 60 mark. So I just said to reduce the intake of gluten. So to start, when she was eating at home and had full control, using things like the chickpea pasta, the millet or chia gluten-free bread, her rice did come up. So I didn't want her focusing on the rice-based gluten-free foods. And then we got the okay from her rheumatologist to put her on probiotics. I endorsed the idea of the iron and the vitamin D supplement, and we put her on a gut healing formula to try and help some of the digestive symptoms she was still suffering from. At the 12-week follow-up, she herself emailed me at 6 weeks and told me that her elimination diet was going really good, that she was starting to notice that she didn't think she was needing the Restoralax as much, and that at times Restoralax was pushing her too far. So she was considering at 6 weeks, stopping using it. At the 12-week follow-up, her iron was up to 19, hemoglobin was at 117, and hematocrit at 0.35. Her vitamin D was at 82. Her white blood cells, neutrophils normalized. She did started reducing Restoralax at week 8. At week 12, was only using it roughly once a week. She was using abdominal pain as an indicator that she was potentially blocking up again, and then would use it and it would go away. A large reduction of abdominal bloating. She was thrilled because she had kids at school ask her if she was pregnant, which was, certainly a trigger for her anxiety. She had a much healthier complexion, and she had gained 6 pounds, which she was very lean at the time that I had seen her. So again, she is still eliminating. Even though we talked about reintroduction, she was dead set against it, just said that she just feels like everything is so good that she's worried about reintroducing. We do have a conversation about that. I don't, when patients have anxiety, I don't want their diet to be a cause for further worry and anxiety. So explaining how reintroduction, keeping the immunoglobulin G levels down is certainly a possibility. She seemed fine. Mom emailed me and said that she's still doing really well as well. Yeah, things are looking up. So that was also, I guess the point of case reviews is to show success. So definitely a success story. Case review number 3. This man is near and dear. I just love him because this is a dog, an old dog who did not want to learn new tricks, but he was in so much pain, quality of life, even just the chronic pain was starting to make him question how much longer he wanted to do this for, meaning live. So to date, at our first visit, he had both knees and both hips replaced. He's still waiting for shoulder replacement surgery. It should happen this month. He has a history and a very big family history. His father as well had almost all joints replaced, osteoarthritis, but also abdominal bloating, GERD, excessive gas, and hypertension. He feels inflamed all the time. The words he used was, "I just feel like I'm a walking flame. Like my body is screaming all the time," and retaining water. So his blood pressure meds, he wasn't on a diuretic, although he probably could have used one. But regardless, the blood pressure med was keeping his blood pressure around the 140/90 mark. His HSCRP level was elevated at 32, keeping in mind that less than 1 is the normal range. The GP could acknowledge the presence of inflammation, but all autoimmune markers were negative. So the GP was just scratching their head, right? Intake of NSAIDs and Tylenol arthritis was multiple times of the day. So we were seeing a slightly elevated liver function panel. That GP was, shrugging his shoulders, going, "Well, it's going to happen, right? With your medication, that's to be expected." So food intolerance test results, again, dairy, both his egg white and egg yolk. He was a very big fan of eggs. Gluten is here as well. Corn at 67 is something that we need to really consider. When I see gluten or wheat and barley, and I see corn and rice or a combination of any of those, I'm always conscious to try and shortlist one of these to make it sustainable. It was with corn at 67, it's hard. Here's we caught a plum here for him. All veggies were fine, which was lovely because we needed to increase them anyways. He was a big fan of mussels, so he was heartbroken with that one. Herbs and spices were all really nice and low. Nut seeds and legumes, and here's a good example. These are all red. Typically in nut seeds and legumes, there might be 1 or 2 that are red. A lot of them are borderline. In his case, they're really, really high. He was a trail mix guy. He says, from the day he was born, he is constantly, he even took a dish out while he was here, and he would shake them in his hand and then pop them out of the end of his, I don't know how to explain it. And then mushroom, which he loved, and his brewer's yeast was borderline. Oh, for mushrooms, I never answered that question in terms of whether or not we would pull all mushrooms out. Generally, yes, we're pulling all mushrooms out. It's not often. I live in Orangeville, guys. It's a small town. I don't see a lot of patients that are eating mushrooms outside of what you can get in our local grocery store. So it's not like I have someone who's, but I grow this really, whatever variety of mushroom. But generally speaking, yeah, all mushrooms come out. So overview of plan. So he was very overwhelmed at all the red on his results. Remember, this was a guy that wasn't really all keen on having to consider this, but was willing to try to improve quality of life. So I shortlisted him to dairy, gluten, eggs, mussels, and peas. I asked him to keep corn off of his plate. So no corn on the plate, no popcorn. I said, if he could find a gluten-free bread, if it's got a little bit of corn flour in that, not to worry. I did have him minimize almonds, cashews, and pistachios. They were the highest, and he did love all three. I pulled mushrooms. I also reduced alcohol, not because it was a glaringly obvious intolerance, but because his intake was too high and it was contributing to his inflammation. I don't have to explain that. So again, same thing, right? He had a lot of gas and bloating, heartburn. So we did a probiotic alongside a gut healing formula. I did get him on a fish oil that gave him 2 grams of EPA a day. And I also threw him on some vitamin D. He had never supplemented vitamin D before. Our plan in January is to rerun all of his blood work, and we're going to check in on vitamin D at that time. At the 12-week follow-up, the pain was significantly lessened. He was down to using NSAIDs and Tylenol arthritis. He had only, in the week leading up to our 12-week follow-up, he had only taken 2 NSAIDs and 1 Tylenol arthritis. He had lost 16 pounds, significant improvement in abdominal bloating and gas, and his HSCRP was down to 12. So while I can recognize we are not normal yet there, that is a significant improvement. This is a good example of someone who I didn't recommend reintroduction yet. I felt like while we had a good improvement in pain, there was just still, I just felt like if we reintroduced, we'd plateau and this would be his new normal. And I know he can do it because he's motivated, he's feeling good. Everything will improve with further weight loss. His surgeon, I think, is going to be thrilled when he sees him later this month that the weight has come down because his post-op will be a lot more easier to do with this new sort of health picture he's got going on. And he's the guy, if you're going to think of compliance, because I also make note at the end of every one of these appointments, I make note of my objective about how compliant I think they're going to be. And my note on him was, I don't expect high compliance, does require a lot of support. It only took, after about 3 weeks, he was on his own. There's a lot of emailing. I had some phone calls with him just to remind him why we're doing it. And then after that, he was on his own. I didn't hear from him or speak to him until a 12-week follow-up, and he's my unicorn, right? He's the guy that with the right support and the right explanations and the right education behind it, these patients can do it. They just need the support. Okay, so that's all I've got. I put my contact info here. So if you have any follow-up questions that you're more comfortable doing over email, if you want to poke my brain about a patient, so you've got a set of results that you're unsure of, you're not sure how to apply them clinically, I'm more than open to communicating with you guys.
Put my camera back on. Okay, so we are doing great for time. It's 1:22. So if anyone has any other questions, everyone is going to get a copy of the recording. It's going to be sent out in an auto email from this platform to all of the attendees, so you'll get to watch a copy of it. I was going to say, if I'm seeing, you can still continue to put your questions in the chat while I'm talking, sorry, but I just want to make sure everyone was kind of aware. Some of the questions that I've been asked, Dr. Danielle, or has anything changed with the RMA test process? So I just wanted to quickly address that to everyone in case you're wondering. That test process hasn't actually changed. You still need to, if you're an ND in Ontario, you'll need to send your patient to a Life Labs along with the FST requisition form and your Life Labs requisition form. The physical location where the test is actually being done has moved, but that should not make any that should not really impact your process. So instead of that test being analyzed at Rocky Mountain in Calgary, it's being done at Life Labs in BC. So that's where the samples are actually going. They still get assessed locally in Etobicoke here first, and then they head over there for processing, and your results are on drop site. So nothing has changed there. If for some reason I'm not able to send out this giant taxonomy document in the follow-up email, if any of you are unable to download it, let me know, and I can send that to you individually. And for any doctors on here that are outside of Ontario, either in BC or in Calgary, I can definitely schedule or connect you with your local territory manager who can answer any of your questions afterwards that we haven't been able to address. Oh, I have another question here. When should we select a candida testing? Great question. Any recommendations based on symptoms presenting?
Yeah, so candida's tough. I find I walk a fine line between, because I have, in practice, I have a lot of patients who come with an initial chief concern of candida, and then when I ask, when I get into more of an investigation, to me, they don't have any signs of candida, the symptoms. So it's not often my approach here, because what you're checking here with candida is elevated levels of IgG to candida, correct, Saroma?
Sorry, I was muted. I think she asked when do you do a candida test? And yes, the RMA candida test, this is IgG candida only.
Right.
That's being tested.
Right. So it's right. So you're looking at, the idea is that, I guess, the more immunoglobulin G you have in your system to candida, that could be indicative that you have more candida in your system. I don't run I've done it twice, I think, because patients knew about it and had asked about it. Saroma, maybe as a rep, you have more to say on that?
Yeah. So the candida IgG test is sort of it's more of a curious, or you want to kind of rule out investigating. So it's not a definitive. It's not going to tell you whether or not you have a candida overburden or growth, but if it comes back positive, it's something that, okay, great, you have something now that tells you need to look into this further. So it's not going to rule it in completely, but it can rule it out, right? And then I have a few other questions. Sorry, I have a long question. I want to get it because we have 3 minutes and I think this thing stops. So Dr. Sonia Carl is asking, and by the way, Dr. Marwa, I can send out the normal antigen ranges. Dr. Sonia Carl is asking, what gut healing formula do you usually recommend? And then there's another question here. She's from Dr. Sue Love, and Dr. Sue, we may reach out to you individually because she's got a specific patient who has ulcerative colitis, who has had a recent flare. Medication options are limited for her. Ran FST back in 2016, and this is what came up: egg white 51, corn 44, plum 37, pea 56, Brazil nut 37, brewer's yeast 44. We tried taking these back out, but she didn't notice much of a change. She was in remission then. Would you suggest to try taking any of these out again? Which would you focus on? First, before you go ahead and answer that, Dr. Danielle, I'm gonna say, Dr. Sue, we usually, our clinical consultants always recommend testing. If a patient has symptoms now, you can run the test now. It's very hard to use results that are from 2016 because it's usually unlikely that patient is eating the exact same diet and is in the exact same situation, 4 years ago. So sorry, go ahead, Dr. Danielle, you can.
Yeah, I would totally agree there. And she said that she was in remission at the time?
When she came back, so it says, we tried taking these back out, but then she didn't notice much of a change because she was in remission then. So when she tried pulling them out of the diet, she was in remission.
Right. So, at that, so they're not good. If she's in remission and she's feeling good, then that tells us, what you have to look at treatment outcomes there. Like, what was the point of the elimination? Did she have other chief concerns that were going on. And yes, that even with an autoimmune disease like that, that's someone that you would, if I have someone who I treated 4 years ago for an autoimmune disease and we checked food intolerances, if I see them again 4 years later, I'm definitely looking at retesting that type of patient for sure.
Awesome.
And the first question you had asked,
the gut healing formula. Yeah.
Yeah, so I generally I use a couple of different ones. I want to look at things like aloe, DGL, L-glutamine, products like Metagenics make glutagenics, Vita8 has GI Restore or GI Restore Plus. That's generally where I sit. I'm also mindful of probiotics based on how heavy is their digestive system, how heavily is their digestive system affected. So I'll use different probiotic. I don't use the same probiotic for every patient. But there's several on the market. But I sit within the glutagenics and the GI Restore generally.
Perfect. And then I believe, hopefully we can still go on, even if it's 1 minute over. One last question came in from Dr. Karen. How long after elimination would you retest?
Mm-hmm. So I did talk about that in the when we had talked about clinical pearls there. So it's not a habit of mine. My initial elimination is 12 weeks when we check in to see what kind of improvement we've had and whether I think it's a good idea for them to start to reintroduce at that time. And most of them are. The purpose of retesting at that point, I guess, would be to see what kind of reduction you've had in the IgG complexes, assuming they're still eliminating, right? I just find, number one, again, you got to take into account your demographic. Working in a small town, I just choose, also part of this decision is a business model, not to retest at 12 weeks. But I think if the patient's done really, really well, I just see a more successful and happier patient when we consider reintroduction at that time. I retest, like I said, whether in that question case where it's been 4 years and she was in remission before and now she isn't, we want to look at what's changed. If the patient has undergone some type of situation where there's potential for a genetic expression shift, so whether it's a major surgery, the birth of a baby, menopause, that kind of thing, we're going to look and see what's changed. Again, there's no algorithm here. It's up to each patient.
Great. And then I think because we have most of the people still here, I'll just ask one question because we did talk about this throughout the presentation a little bit, but maybe just get a direct suggestion from you and I do get this question a lot too. So again, in that same vein of patients wanting to retest, how do you sort of set them up, or how do you make sure that they kind of understand maybe at the beginning what the expectation is? Because I hear a lot of patients wanting to basically do the test, do what they need to do to lower these IgG reactions, but then they basically want to eat the same exact foods they were eating before and want to retest. And then obviously if they haven't been eating those foods and you retest, well, they're going to be green because you no longer have those IgGs in circulation because you're not being exposed to the antigen. So how do you sort of get that patient into the right frame of mind so that they understand what their expectations are and kind of what their lifestyle change, or how do you make them more accepting of a lifestyle change? Let's just say that.
Sure. And I think that's where, we spend more time with our patients, and this is where we can really have an impact in terms of educating and empowering, and also just I feel like you've got to really if you're a newer practitioner, the more patients you see, the better you're going to be able to really read them and know how much encouragement and information do they need before they get it, right? So the very first thing when I consider food intolerances potentially playing a role in the patient's chief concerns, I'm going to say, okay, look, here are our options. we can look at food intolerances and do a short term. I don't tell them 12 weeks yet. I say a short term elimination. We'll do some gut healing, and then we'll look at what kind of a role they can play in your diet. If you don't want to change your diet, you are looking at the management of your IBS using supplements or medications potentially for the rest of your life. And some patients choose that. Some patients say, look, I want nothing to do with the dairy elimination or whatever. And I'll say, oh, no problem. We will supplement for this, but just know you're not going to get the same benefit you would if we identify a food intolerance. And some of them go, okay. I'll also say to patients like, look, if you're going to spend the money and do the test, you want to do something with it, right? Let's just not do this for information. We're just going to file in the back of our brain and think maybe one day I'll do it. Like if that's your approach, we're not doing that. Right. And I'll also say to patients, like, you tie my hands a little bit and I say, you're here for a reason. You've seen all the doctors, you've tried all the medications, and you're still taking Restoralax twice a day, and you still need to, use an enema once a week. Like it's time for change, right? Remind them why they're there. Remind them that they are the ones saying, like, I need help. I can't, this isn't being managed. And really try and have the conversation where you're not, we are going to try eliminating, not you are going to, like, it really is, you want to be mindful of the therapeutic relationship and let them know that you're here to support them. Also, I'll also give, like, even right now, I gave a set of results today that were really, really tough, and it was for a 6-year-old girl, and the mom was really upset. I mean, this wee girl eats a lot of Kraft dinner, a lot of hot dogs on her school lunch, a lot, like, yogurt is her mom says it's her main caloric intake. So working with the mom to say, okay, let's just spend from now until January wrapping our heads around this. Start researching. Like, you want them to know that you're with them. I do, much to my husband's, demise, I do offer support through email. And I don't charge for it, so I do get a lot. I do every night. I'm getting like 7. Can I have this? What about this? These are really quick, but they feel supported. They feel like they can do it. So it is. Sometimes you feel like you're hand holding, but that's okay. I mean, that's what they're paying you for. And right before you even get to the result part, as soon as I know, okay, let's do this. Let's check for food intolerances. I tell them right then and there, okay, here is what to expect. When I get your results, we're going to go through them. We're going to identify your elimination. We are going to do an elimination for 12 weeks while we heal your gut. We're going to talk about reintroduction and moving. And then I tell them, you go back to the way that you're eating now, you will be right back where you are, sitting here in this chair today.
Right.
Like,
right.
This is going to be something you carry with you moving forward. It may not mean a strict elimination for the rest of your life, but you are going to learn over the next 12 weeks how to eat food that will make you feel better. And then when they start, right. Like I said, majority of my patients coming back at 12 weeks are saying, you know what, I feel fantastic, that a lot of what I've learned, I'm going to continue using moving forward. It's really not often that I see someone 2 years down the road. It is not often where they're going, I screwed up. I'm back to eating everything, all the things, and now I feel like crap again.
Wonderful.
Right? So it's just full transparency, support, educating them, making sure they walk them through the future with you either learn and carry it through, or you decide it's too hard and you don't do it. But okay, so then we are now subscribing to supplements and medication.
Right.
Which is fine. I mean, you don't give judgment for that, right? You can't. It's not our life. I never would judge someone for choosing not to make the dietary changes. I would just explain it's just a harder hill to climb. It's just going to mean it's going to be harder to manage. But
right. Well, thank you, Dr. Danielle. We've gone quite over time, so thank you for everyone who stayed on to listen to the last bits of the questions. You will get this as a recording, and that's a great point, Dr. Danielle. So that was really great insight. And I will send out the additional documents that we discussed. And you'll also get a webinar survey. Please take a chance to just enter those survey questions. It helps us to make sure that we're providing content that's helpful to you all. And thank you again, Dr. Danielle, for your time today and for putting this presentation together for the Rocky Mountain community. Thank you.
Yeah, you're welcome. My pleasure. Thank you to everyone who attended and asked questions. It was great.
Great. Bye, everyone. Good afternoon.
Bye.